Welcome. I'm Catherine Magana here with Steve Wolf, Rachel Ivanovich, where we're here to provide some insights about the markets, investing, and planning. And we also have a returning special guest joining us today, Pam Morton, who is here to continue the conversation on Medicare planning.
I guess she likes torture.
So before we jump into that, just an update from the markets from last week. The last few days, the markets have pulled back a little bit. Not a major move, but the markets are down a little over 1.5% since last week. Today's October 23rd. And then, today's October 24th. I'm missing days, but it's based on yesterday's numbers. And the S&P 500 was down a little bit. But the major move I saw was the 10-year bond, which is actually up since last week. But that's been moving around a little bit. It looks like on the S&P 500, there's about 32% of the stocks have reported their third quarter numbers, and 76% of those have beaten expectations. So we expect more news to come on that front. And then it does look like still talks about the chances of a rate change with the Fed. It looks like there's a 95% chance this week that the Fed will lower rates by 25 basis points at the next meeting. But anything could happen between now and then, but that's what it looks like. And it looks like potentially maybe that might be the last rate change for the year, but we'll see.
Well, there's only, I think, 12 more days left until the election.
Yeah.
And, I think that has something to do with what the market's doing right now. Truthfully, I mean, the earnings are coming out fine for the most part. I mean, what'd you say, 70 or 80%?
So 76% have beaten expectations.
Yeah,
so
the 76% is a pretty good number.
Yeah.
So if that continues, then, I think that the stock market will hold up. But it's also interesting to hear people who are trying to bet on who's going to win and which stocks they're buying and what they're doing. So, well, we've got 12 days more of this. Talk about torture. 12 more days left of this. It seems like it's been forever, and I'll be glad when this is over.
Yes, I think, well, we also know where we're at in October, that before we know it, the year will be over. So just...
Yeah, the other thing, too, is that people forget about is that mutual funds have to do whatever selling they have now as far as tax purposes, because I believe that if I'm right, I think that their fiscal year ends at the end of October.
And they start doing their capital gains distributions.
Right.
Yeah.
So they may do some selling if want to get some losses. All we do is talk about taxes.
We love taxes. It's the best time of year to talk about taxes.
Well, wait, before we get into Medicare, speaking of taxes, I just read something that gives me hope. North Dakota.
Taxes and hope in one sentence. I love it.
It's unbelievable. North Dakota is voting on a measure that will eliminate property tax. Okay, So if that catches on, that would be pretty great for the individual. Now, of course, the states will have to say, okay, well, where do we get the money from if it's not from that?
Yeah.
All right, but it is interesting that people are finally rebelling against the amount of tax that we pay. Which is one of my big bugaboos, especially as a business owner, and we'll probably get into that in a little bit, right, Pam?
That's right.
Mm-hmm. As you're talking about taxes, we're actually now at the end of the year, there's tax loss harvesting, there's some tax planning. We'll definitely kind of bring that back into conversation over the next few weeks. But
see, we talk about tax loss harvesting. The only thing we should be talking about is harvesting our crops at this time of the year.
There you go. Okay. All right, so let's turn it back over to Medicare planning. After the podcast we did a couple weeks ago, we had a lot more questions, and so we asked Pam to come back and join us again. And one of the things that came up for us was we have clients that are, we talked about approaching Medicare planning age, but we also have a lot of clients that are actually already the age where they have Medicare. And so the question was, if you already have an existing plan, when should you review it? Is this a good time because of some of the changes, or how often should you be reviewing that?
All right. Well, I'll start by talking about that a little bit. The first thing to mention is that for people who have Medicare supplements, they really don't need to change those very often because all the plans are standardized, and the insurance companies usually are pretty good about not having steep rate increases because they know that all the plans are they're all the same structurally, and they want to be competitive. So you can see an annual increase for your age. You can possibly see an increase when the company overall does a rate increase. Usually that's in the spring. And then something that people forget about is that when they're first 65 or first getting Medicare, and they may take a policy that gives a $25 a month discount. It's called a Welcome to Medicare discount. So the first year when you get your renewal, it looks like it's really gone up a lot, but you have to remember that that $25 may have been part of that equation. And then if someone wants to change their Medicare supplement, they can only do that during their birthday month. And we have a special law here in California. It's called the birthday month rule, and that's when you change your Medicare supplement. So during your birthday month, you can look at other companies. You can make a downgrade, or you can choose the equal plan. So if you have a plan F or a plan G, you can keep that same and choose a new company, or you can downgrade it. And then for the Medicare Part D plans and the Medicare Advantage plans, they have an annual election period, which we're in right now, from October 15th to December 7th. And then in January 1st to March 31st, if you have a Medicare Advantage plan, you can change the Medicare Advantage plan during the open enrollment period.
Got it.
And so those are really the 2 times a year when you can make a change. Most people buy their Medicare plans and they just keep them. They really don't make changes to them. But I would recommend that occasionally you take a look at your Medicare Part D plan if you have that separately outside of a Medicare Advantage plan, because each Medicare Part D company has a different formulary, which is the list of drugs. And then they have different financial arrangements with both the pharmacies and the pharmaceutical companies. And so if you were to look at 2 quotes side by side, you would see that the actual cost of the medications is different on each plan. So if you have a change in your medications year to year, you really should take a look to see if you have the best cost plan for the medications that you're taking. But if you really don't have a change in your medications, and you get your annual notice of change mailing in September from your Medicare Part D or your Medicare Advantage plan, and they don't have a lot of changes, then you really don't need to take a look at it. So that would be really the guideline to look at in terms of changing plans.
And then if somebody is approaching 65, can you kind of share when you should start looking at your Medicare options and planning?
You can apply for Medicare Part B 2 months before your 65th birthday, and then up to 2 months afterwards. So if you're not currently working at an employer where they're providing your insurance, that's when you would take a look at that. You have the option to, if you're working for a company with more than 20 employees, you have the option of staying on your employer's plan until you're no longer working full-time, which they consider 30 or more hours a week. And there are some penalties for not taking Medicare when you're eligible for it. But if you stay on an employer plan, then you can avoid those penalties, and you'll have your initial enrollment period at the point that you leave the company, and will no longer have your benefits.
So what kind of penalties? I mean, do they put you on the rack, or what do they do, Medicare?
They have a penalty per year for Medicare Part B. And then for Medicare Part D, they actually look at each year's average national cost for Medicare Part D plans, and they have you pay 1% per month that you didn't have a plan.
So we talked a little bit off camera here about the cost of Medicare, especially for business owners, especially business owners who are over 65 and are still working.
Uh-huh.
I know we had a discussion about this, again, off camera, and you can take my personal experience if you'd like, but I am working. I make a decent salary. My Medicare is not cheap. We figured out that maybe it's about $5,000 or so, but with the supplement and everything else, less than if I stayed on the plan. Why is that such a good deal? Because, in my opinion, Medicare doesn't cover a lot of the things that the private plan does.
Well, the first thing I would say is that really in that equation, because you're a business owner, you're looking at it's almost like a double taxation because you're paying taxes
Not
as
almost.
a business owner.
It is double taxation.
I try to be, light on that. But you're right. You're totally right. And so you do have to consider that because you want to look at what your options are in terms of your total cost. And if you're also a business owner, you want to look at your total cost as a business owner and also your total cost as a private citizen who may be going on Medicare. And in previous years, a lot of people decided to stay on the employer plan for some of the reasons you're talking about in terms of having perhaps better coverage. For prescription drug coverage, that was definitely true. And so if you are on an employer plan and you're over 65 and you've stayed on that because of the medications, you do need to know that this year there's a $2,000 cap on the medications, on your co-pays for medications now with Medicare as a result of the Inflation Reduction Act. Some of the other concerns that you can have would be access to providers because on the employer plan, you're dealing with a network that the employer plan has as part of the plan. Once you're on Medicare, you do have to see a Medicare participating provider, which really just means that the provider, whether it's a doctor, some type of a specialist, a hospital, whatever, they have agreed to the fees that Medicare is willing to pay them, which is a reduced schedule. And so there are some physicians now that are not wanting to take Medicare patients because they don't want to have to take the reduced fee. Something that's not super well known is that providers are allowed to charge up to 15% over the Medicare allowed amount, and so of course most providers are going to take advantage of that, but that's still not anywhere close to what they would get for an employee who's on an employer plan. And that now after the pandemic, we've been seeing a lot of providers, or a lot of especially primary care doctors that have been retiring, and they're not replacing them fast enough in the market, there's, for whatever reason, and not in there. Maybe it's more beneficial for them to be a specialist. So we're seeing an actual shortage now of primary care doctors.
Again, Pam, you're saying maybe it is more beneficial for them. The people who are primary care physicians are working their fingers to the bones, and they're not making nearly the money that the specialists are making, and that's part of the problem. This is my personal opinion. I think the whole thing is like a Ponzi scheme anyway, and it's the only thing the only industry that I can think of. Maybe there's something else in our country where the actual person who gets the benefit doesn't actually, barter or whatever it is,
Negotiate.
with the person who's giving. Okay, we have a third party that's doing it, whether it's the government or whether it's an insurance company, doesn't matter to me. If I were to go into a doctor and he said, well, it's going to cost you $15,000 to whatever, and I couldn't afford that, then I'm going to try to find a doctor elsewhere. You can't do that in our system. And you can't do that, so then they say, well, what about, systems like in Canada and Britain? Well, that's great, except that they're going broke. Okay, and they have a system where if you're old and you need a lot of medication, they're just going to say, we can't afford it. We're going to give that to the younger people. So I think our whole system, to be honest with you, is broken. I don't know how we fix it. I don't have that answer. I wish I did. But this whole thing with Medicare and Social Security, I'm getting off on a rant because this really bugs me. Okay, Social Security. We pay into the Social Security system as well as Medicare our whole lives. And as the employer, by the way, we also pay for everybody else's. All right, and that comes right out of our pocket. So all these people say we don't pay our fair share. That's a bunch of hooey. Okay, so at any rate, I'm on a roll here. All right, so we pay into Social Security all that time. All right, we get Social Security, and because we're working, guess what? Not just because we're working, okay, but because we're getting it, we're being taxed on it again. What kind of a system is that? I mean, really. So, yes, you're a Medicare specialist, and I understand you have to work within the system, but maybe we need to start thinking about a different system.
Well, there's always been, for years now, so many different opinions and policy, legislation and everything else suggesting alternate systems. And I really think that if there was one that was really great, maybe one in another country, we probably would have just adopted that. But it's just so complicated. And during the pandemic, a really good example of that was when all of a sudden the insurance companies were charged with doing the COVID shots and paying for the care, a lot of the care, and they really didn't have enough coordination, and so that's why we had shortages for supplies and other things like that, because everything is so separated. There's, when you think about all the hospitals we have here and, San Diego and everything.
But again, Medicare doesn't really pay what doctors should be getting. All right. I mean, again, personal experience. I had back surgery 2 years ago. All right. Fortunately, they took Medicare. I was on Medicare. I was probably the last person that he said, I'm going to take it, because he was getting paid nothing for what he was doing. He told me that it wasn't even covering his costs. So again, I guess if you're not sick, Medicare is great. That's, as a matter of fact, all the socialized medicine is great as long as there's nothing wrong with you. You go to the doctor, it's, quote, free, although you pay for it in taxes. So nothing is free. All right. But here we have a system that isn't giving the doctor what he really should get. I mean, if I were somebody and I'm going to take out $300,000 or $400,000 in loans, I want to at least get paid for what I'm doing,
I totally understand, but it's really a symptom of cost shifting that we're seeing throughout the industry, because you have the Medi-Cal reimbursement as the very lowest, then you have the Medicare reimbursement, then you have the private insurance, and then you have the people who just pay cash. And there's just a lot of cost shifting.
Are there people who just pay cash?
There are people who pay cash, yes. So
how do they afford it?
Well, I know someone that paid cash because he went into the emergency room, thought he was having a heart attack, and ran up a $25,000 bill with no insurance. And basically he was stuck with it.
Could he negotiate and say, I'll give you X amount, I don't have $25,000?
He did negotiate, but it was still a lot of money, and he was paying for that for a long time.
Okay, but again, and so he was paying less. Again, another personal experience. My kid, when he was 6 years old, broke his elbow. Okay, and at that time I didn't have a pot to pee in. And they told me what, it was. I said, how much is it going to cost? They said, well, don't worry about it because insurance covers it. I said, I don't have insurance. Oh, you should have told me that. If that's the case, they lowered it by 50%. And that is my point about Medicare, socialized medicine, all that. And I think it's the doctors who get screwed, to tell you the truth. Mm-hmm. Matter of fact, I think it's the doctors and the patients. They're both getting screwed because the amount that we have to pay for the insurance is ridiculous. All right. Now, I know that has nothing to do with how Medicare works and all that, but, we get on this topic and it just really roils me.
I think it's not just Medicare, it's the healthcare industry in general. Healthcare costs go up every year.
But why? Why is it that much? It's because there's a third party determining, well, we're going to pay X amount. Yeah. Whether you like it or not. Yeah. And you're the,
I think that's a whole other conversation of changing the whole system.
Well, I know it's another conversation, but we're talking about it now.
But I think that what's probably going to be looked at before anything, I know we're talking about Medicare, but it's probably Social Security. I think that's probably something that's going to have to get looked at.
But Social Security is a problem we can take care of because we know pretty much what life expectancies are.
Correct. But I'm thinking if anything is going to be prioritized, that's going to be looked at probably before Medicare.
Well, you're right. But the problem with Medicare is we don't know what those costs are going to be.
Correct. Well, yeah, and we have so many aging into retirement and over 65 and
so how will it be even possible for Medicare to keep up with that unless they say we're only going to pay X amount, and then the doctors are going to say I'm not even going to take it.
Or they do what they did with Social Security. Social Security used to be 65 and now it's 67, and they keep pushing that out. So who knows? I mean, there definitely going to have to be some changes. It's just, what does that look like?
Yeah. Or there'll be an additional Medicare surcharge. Currently, if you make more than $250,000, there's a 3.8%.
You know what? They can't. There's not enough people who make that money to make that system solvent.
Yeah,
that's the problem. That's the problem with all the socialized medicine and socialized systems. You get that I'm not much for socialized stuff.
Yes.
I like the free market because it works. So how can we get back to a free market system? I don't know, because we're so far down the line on this, and people think we should go further down the line. But I really wish that they would look at some of the places that have socialized medicine. And people think it's free, and people think it's great. You got a hip surgery, and look, I'm in that period right now, in that age group, that we're talking about knee surgeries, shoulder surgeries, hip surgeries. We talk about every surgery you've ever heard of, okay, or anything else that's wrong. And you know what? If you're in the socialized system and you need a hip surgery, it could be 3 years before you get it, as opposed to at least, maybe it's only a couple months here. You know?
But I just think in general, the whole system, because I know when we had the twins, which is many years ago now, but they're 15 and a half now, they were both in the NICU for 5 to 6 weeks. And the cost of that, I mean, it would have been $500,000 each of them for all of the care and everything that was required. So once again, we had to pay out of pocket, but we didn't have to pay the hundreds and thousands of dollars. So that goes back to the pricing. Is everything priced correctly or not? And that's a whole nother discussion and question.
Right. Well, I would almost guarantee you that the pricing wouldn't be anywhere near that because nobody could afford it.
Yeah.
Okay. I mean, that's the whole point. All right. So anyway, getting back to
Medicare.
I have a question for you because I'm not on Medicare, and there are a lot of people that listen to this potentially don't know. So can you explain what the different parts are? You've alluded to Part D quite a few times, and I believe that's prescription drugs.
Correct.
But can you explain the different parts of Medicare?
Sure.
Will they pay for non-prescription drugs?
No.
Like stuff you get off the street or anything like that?
Why do you need some of those right now?
Because right now I think I
Steve's
need
like,
it.
I need one right now.
Well, there are 4 parts to Medicare. Part A is hospital insurance. And hospital insurance covers you for hospital, also covers some skilled nursing benefits, the first 3 pints of blood, and then some of the hospice care, although hospice care is actually covered by Medicare. But that's all considered under Part A of Medicare. And then there's Part B of Medicare, which is also called medical insurance, but is actually for your outpatient services. So doctor's visits, durable medical equipment, outpatient surgery, basically everything that's not in the hospital. And then Part C of Medicare is actually Medicare Advantage. And so if you were to purchase a Medicare Advantage plan, it's kind of, it's an all-inclusive package where it covers Medicare A, hospital, Medicare B, medical insurance, and Medicare D for drugs. And then you're right, Medicare D is drugs.
And then you alluded to Plan F and Plan whatever. Can you explain what that's all about?
Sure. So the government has some standardized plans that you can choose from, and each insurance company has the opportunity to either offer a standardized plan or they can offer another version of it. Each insurance company has to file their plans with the Department of Insurance. And so for the companies that offer the standard plans, which is most of them, it makes it easier from a consumer standpoint to decide which one you want, because if you buy a Plan G, as an example, which is what most people purchase these days, then every company that is offering a Plan G, it's going to be a standard Plan G, and the benefits will be exactly the same, but the rate per month will not be the same.
What do you mean it won't be the same? Will it be less, more?
Each insurance company sets their own rates with the Department of Insurance, and it's based on your age and your zip code and if you're a smoker.
So is the government then deciding what will be paid, or is the insurance company deciding the amount?
Medicare is billed by the provider. They pay their portion, and then they send your bill through a third-party administrator to your supplement plan, and they have to pay the rest.
Okay.
You talked about Medicare Part A and hospitalization. I know that there's certain rules about when Medicare will actually pay for you to be admitted to like a skilled nursing facility. And can you illustrate that a little bit and talk about that?
Sure.
Because I do know my mom got hit by a truck and ended up in the hospital. And I heard from a lot of people, make sure she's in the hospital for a couple of days so that Medicare will actually pay for the skilled nursing afterwards.
It's a 3-day.
It's a 3-day.
A 3-day hospitalization, and you can be qualified to move to skilled nursing. But you do have to require some type of skilled care from a registered nurse, and not just your activities of daily living type care, in order to have that covered by skilled nursing. And then they'll cover you in skilled nursing usually for the period of time that they feel that you're improving. And once you're not improving, or they don't think you're improving, then they'll serve you with I say serve, but it's not like if someone comes to the door. But they'll give you
like a subpoena.
Yeah, there you go. They'll give you a 5-day notice to let you know that your skilled nursing coverage is going to be ending.
Because Medicare does not cover long-term care.
That's correct.
But they do cover some skilled nursing after a hospitalization.
Mm-hmm. It's usually for rehabilitation, for instance, after maybe a knee surgery or hip surgery or something where you're just not ready to be on your own. You're still taking medications. Sometimes you require an IV medication that would keep you in the hospital, or some type of care that you can't get at home.
So in order to pay for that, would somebody just have to have some supplemental insurance?
They can have a long-term care policy, and so if you have a surgery like that and you have a long-term care policy, even though you know you won't be on long-term care for a long period of time, it's a good idea to notify your long-term care company, because that can help you with your elimination days. So you can say, hey, I can't, bathe and dress and whatever, my, 3 types of activities of daily living. So I want to let you know that, that I am going to need some long-term care. Obviously, if you're going to just recover from a surgery, you won't be there a long time, but it's nice to kind of check off some of the elimination days.
The interesting thing is that a lot of the long-term care insurance policies are gone. A lot of companies don't want to do it again because it goes back to costs. They couldn't charge enough to make it worthwhile. Now, there are some life insurance policies that have a rider for long-term care. We've been able to find some of those, and that's make a little bit more sense. But the cost of long-term care insurance almost doesn't pay for it, especially if you have a lot of money. I think a lot of people will self-insure.
I absolutely agree with you. I mean, I remember my mother-in-law had a policy, a long-term care policy, and we got the inflation rider as well. And so she went into the type of she needed the type of nursing care that was memory care, and it was very expensive. And because she had gotten her policy a long time ago when they were still offering those good policies, she was very well covered financially. But these days, it's more like a help pay. We'll cover you for, X amount of dollars, but it's only for like 2 years or something.
Yeah, I think the old policies, there were some that there was no limit, and
there was
they
no
definitely now have different requirements, and the premiums have gone up too for those straight policies.
I remember when these kind of first came out, the long-term care policies, and they were talking about those non-limits, and I would ask the people, I said, well, how are you going to pay for this in the future if rates, or not rates, but the costs keep going up and up and up? And they assured us so that wouldn't happen. Of course, it did, and it will continue. This is a tough problem.
It is, and the actuaries were wrong.
Exactly.
Basically, that's what it comes down to.
And that kind of takes me back a little bit to the Social Security thing. The actuaries pretty much know. You know pretty much, on average where people are going to live, how long they're going to live. So you have some choices there. You can either say we'll pay less. You can say that we'll pay it later. You can do that and pretty much know that that's going to work. That's not the case with Medicare. Would you agree with that?
Absolutely.
Yeah. So interesting. I mean, I'm glad there are people like you who can help us solve some of these problems as far as what to do. My issue is a little bit more deep than that, and so I'm not mad at you.
Oh, I know. I'm sunshine girl over here. So
Yeah. Don't kill the messenger, right?
Right.
All right. Well, I think that's going to be it for this week. I've gotten my vitriol out pretty quickly. So,
well, I do have a couple more things, if you don't mind me just
okay,
adding
well,
on
let's
here.
keep going.
So, if we're okay on our time.
That's
so,
right. Just a minute. We have to take a commercial break. Okay, we're back.
Well, the last time I was here, the annual enrollment period had just started.
Yes.
And sometimes in the beginning of an annual enrollment period, we have a little bit of instability with some of the carriers and then the information that's available. Most people will depend on Medicare.gov as a resource to find their Medicare Part D or Medicare Advantage plans. And so typically during the first couple weeks, maybe the data isn't that stable, but I do want to say that so far this year, the data has been stable. And so I'm at the point now where I'm really comfortable making my recommendations for people. And then the landscape has really changed on the Medicare Part D plans. I think I might have mentioned this a little bit before, but now that there'll be a $2,000 cap in 2025 for what a person would have to pay themselves for their medications. You're seeing a big difference if you look at the Medicare Part D plans in monthly premium. So the lowest cost monthly premium for Medicare Part D in this market is a Cigna plan. It's only $1.80 a month. So you have to ask, well, how can they do that? Well, they can't. They're buying market share. And the plans that were doing better, that really didn't have very much in the way of an increase this year, are the plans that were charging over $100. The plans this year for 2024 that had a monthly premium of over $100, they usually did not have a deductible as well. And so they had already kind of built that into the price by not having a deductible. And so the plans that were in 2024 costing around $100 or more a month, those prices have stayed pretty stable for the renewals. And so for any of your listeners out there that had a plan that the monthly premium was about that much, you probably didn't see hardly any change for 2025. But if you are a person who doesn't even take any prescription drugs, you want to make sure that you still get a Medicare Part D prescription drug plan because of the penalty. But at $1.80 or maybe $17 a month for another plan has a monthly premium for that, it's worth it not to have to pay the penalty in later years. So I just wanted to mention those last couple things.
So the limit that a person will pay out of their pocket for drugs is $2,000 now.
Yes.
And you said the premiums, the cost of that by insurance companies have gone up.
Yes.
Is that right? They've gone up so they're covering that anyway.
It's more cost shifting because it was $8,000 was the maximum in 2024, and now that's gone down to $2,000. So the Medicare Advantage companies have been eliminating plans for 2025, consolidating plans. We're seeing some premiums go up a little bit, but you can't go up that much because some people won't be able to afford to pay them. And then they're raising the monthly premium, especially on the Medicare Part D plans that were very inexpensive before.
Okay, so as a whole, we're paying more for the insurance to make up for that cost.
Yes.
As my economics teacher once said, Tanstaffel, which stands there ain't no such thing as a free lunch.
That's right. The nice thing, though, is every year you can change your plan if you want to. So if you had a plan last year that was 40 cents, which there was WellCare Value Script last year was 40 cents in this market. Now they're charging $17.40 going into 2025. They might still not be covering their costs, I guess is my point. So,
which means they'll probably keep raising those rates as time goes on.
Yes.
They have to.
They will.
In order to cover their costs.
Mm-hmm. I mean, not everyone is going to use more than $2,000 or even $8,000 worth of medications, but there are a lot of people that are kind of at that $2,000 limit. So,
right, well, that's what insurance is about. I mean, not everyone dies at
Right.
the same time, so that's how life insurance works. It's how all insurance works, But a lot of people are paying a lot more than they would for the few people who aren't. That's what insurance is. I'm not saying that is a
true.
bad thing. I'm just saying that's how it works.
But I think going into 2025 and seeing how the experience goes from this year, maybe in the next couple of years, I think you'll probably see less Medicare Part D plans. You'll probably see some type of consolidation of those as well, because they'll figure out what their actual costs are going to be once that starts to become more stable.
What happened here recently? I know Scripps, I think it was Scripps, said they wouldn't take some policies. What was that all about?
Scripps didn't want to take Medicare Advantage contracts any longer because they weren't profitable for them. And so they said, we're going to cancel our contracts with the Medicare Part D companies in the area.
Is that something that we should worry about that other companies are going to do?
It's a possibility for sure. I mean, I think we've had high reimbursement to the insurance companies the last 10 years for Medicare Advantage. We saw a slight reduction for 2025 to the insurance companies, so that's one of the reasons why they're cutting back on their plans. Provider issues kind of come and go. I mean, I've been seeing a lot of notifications for provider groups that are having a hard time negotiating their 2025 contracts, and they're at the point where they're sending letters to people and whatnot, but most of those will end up getting resolved.
So for some, I'll use business owners, but really just for some wealthy people, I know that they're going to concierge medicine. Mm-hmm. How does that play in with Medicare? Because I wouldn't think that they'd take Medicare. So what, do they have to have a supplemental plan or something? Do you know how that works?
I do. So the concierge plan is really on top of your Medicare. So if you have a concierge plan and let's say you have to pay $200 a month for that to that medical practice, you would continue paying that regardless of the fact that you have Medicare.
So you can have both.
You can have both.
But the concierge, they won't take, they don't get anything reimbursed from government. That comes out of pocket. from the individual?
They're going to get whatever Medicare reimburses, plus they're going to get their extra $200 a month or whatever it is they're charging to the consumer.
Okay.
But they still have to accept the Medicare rate.
Okay. So is that a good thing, bad thing? Well, what's in your opinion?
Well, I think that if we're talking about access to care, and you know that you really need good access to care, that sometimes the concierge method is advantageous.
Right. Well, hopefully we can figure out some system that really works for everybody. I know that, the argument is always that, well, poor people can't afford their medicine. And I get that. There's probably truth to that. But there's got to be a better way of doing it where the whole system is not overpriced.
I understand. I mean, the people who are on Medi-Cal and Medicare, their best option really is to be in a Medicare Advantage plan, because then they pay little to nothing for their medications.
Right. But the people who are on Medi-Cal and Medicare usually are people who really have very little, if not, almost nothing.
Absolutely.
Okay. And that's not the majority of people in our country, but it is a sizable amount. Mm-hmm. So, I'm not a Grinch. I want those people to have care, but there's got to be a way. Yeah, I'm sure there's people who are a lot smarter than I am who are trying to think of how to do it, but we'll see. Anything else that you've got, Pam?
No, that's it.
That was great. It really was. I enjoyed this. Now I can go the rest of the day. I feel pretty energized, We'll see you guys next week, and thanks for listening.
Great. Thanks for joining us, Pam.
Okay.
Thanks.
All right, I've got one more thing I'm going to tell you. I didn't want it to be on the mic.
Okay. Keep it going.
Do I need to turn the mic off?
I would.
Keep it going. We can always...
It goes to your point about...
Keep it going.
All right.
Are you okay with that?
It's fine.
We can always cut it out.
Okay. So what I was going to say is that in our country, our system is based on the employer paying for medical care as an employee benefit as part of their compensation. And so all of the suggestions that we've had about socialized medicine or different things along those lines, those usually do not include the employer part of the financing of the plan. And so, in other words, if they just said, okay, we're all going to socialized medicine, and all of a sudden the employers go, woohoo, now we don't have to pay for that anymore. Well, that is nice for the employers, but that's why when you hear the estimates on what that would actually cost, it's so expensive, because it doesn't include that portion of it that's currently as part of the system now.
Well, no matter where it comes from, it's a big pool. Whether it comes from this side or that side doesn't matter. It's still going to cost X amount of dollars.
Correct, but you're saying that the companies are paying that right now.
Right.
So where is that going to come from? If we go to a socialized system, where is that going to come from? Then maybe there's an employer tax or there's some other tax on the employers, but...
Right.
I agree. I mean, I think that the socialized system is not the best system. Mm-hmm. And we seem to want to push for that. And I look for it in other countries where literally they're going broke on that system. Mm-hmm. That there's got to be a better way than that. So I see what you're saying.
It's not something that favors my livelihood, but it is reality.
Well, if I remember correctly from what I was reading, employers didn't used to do this. What happened is that there were unions who decided that they wanted their Medicare to be, or their medical expenses to be paid for either partially or all the way. So in their contracts, they would start doing that. Well, when one company started doing that, then the other company started doing
Correct.
that.
And I bet you when that happened, you started seeing eventually a shift from pensions to the retirement plans. And so that from pensions to the healthcare plans. So there's not these big pensions like they used to have. I mean, they have 401k plans, but the amount they're putting in is minimal to these big pensions that were out there.
Exactly.
I'm working with a Canadian company right now, and they have the majority of their benefits are just covered by the national Canadian healthcare system. And so what they're paying for supplemental benefits is pretty small in comparison. And they have a few company executives or employees in California that need benefits, and they just can't believe how much they're going to have to pay for them. So,
but they're already paying for them at their taxes. Their taxes are extremely high.
They are paying for them, right? But it's just from one budget to another.
Right. So it goes back to my point, though, is that whatever the cost is, it is. How it gets paid for is what we're talking about. From which pocket it comes out of.
Exactly.
So, again, I still like the capitalistic systems, the free market systems, if there are people who can't afford it, okay, we're a wealthy country. We should be able to help those people. But I think for the majority of people who aren't destitute, I'm not sure that the socialized medicine is the right way to go.
I would agree with you.
Well, good. All right. Pam, the Medicare person, agrees. We love that. All right. Well, again, I think this is a wrap for this week. We'll see you guys next week, and we probably will have more on markets rather than healthcare. Take care. Thanks a lot. Thanks for listening.
Thanks, Pam.
Bye-bye.
Thanks.
Please stay tuned for important regulatory disclosures. WWM Financial is an SEC-registered investment advisor. The opinions expressed in this program are for general informational purposes only and are not intended to provide specific advice or recommendations for any individual or on any specific security. It is only intended to provide education about the financial industry and how we may be able to assist. To determine which investments may be appropriate for you, consult your financial advisor prior to investing. Any past performance discussed during this program is no guarantee of future results. As always, please remember, investing involves risk and possible loss of principal capital. Tax considerations presented may not be appropriate for every individual circumstance. A tax professional should be consulted before making any decisions about your tax liability.